Once you have access, then the portals are enlarged, and in my case I use a capsulotomy knife first, taking care not to damage either the labrum or the femoral head, which is that structure on the right. Once the incision is made, then more space can be created using the 90-degree burner. Again, being careful not to damage any of the other structures. Once good access is achieved, the labrum is then assessed in its entirety, and about 90% at least they will be solid, although there may be some fraying at the junction, and this is easily dealt with by using the burner. Occasionally there will be chondral damage in this area, and in most cases this can be simply debrided back and stabilised. If there's a significant defect, it will be removed and the bare area will be microfractured. Any loose areas are debrided back until nice and smooth. Once any labral and chondral abnormalities are dealt with, it's important to look at the rest of the joint. And here we're looking at the ligamentum teres. It's a strong structure, very similar to the ACL, which is relaxed in internal rotation and tight in external rotation. We're still not really clear as to the true function of it, but it does have blood vessels and nerve endings. That's the transverse acetabular ligament, and we'll slowly work our way around the posterior labrum to look for any further abnormalities. This is done using the 70-degree scope. The peripheral compartment can be quite difficult to enter, and it's usually done via two ways, either by swinging across from the central compartment, which involves making a large capsulotomy, or making new entry points altogether, and this is the hollow needle again with the fine wire passing through it. And once you're happy with the position, other instruments can be railroaded over that before you do a thorough debridement of the inner aspect of the capsule. Once your instruments are in place, it's then important to create enough space for you to work in. I then mark the front of the head-neck junction where I'm going to start my resection, and I use X-ray for that. It's important not to resect too high up the head, and I also find it useful to debride enough of the capsule to ensure that I can see the labrum. And we can start to see the labrum coming into view here now. In many ways, the peripheral compartment is the more fiddly bit of the hip arthroscopy procedure. It is very easy to underdo your resection. When I carry out the head resection, I use a 5.5 bony burr. I feel that this gives me a smoother resection margin. Again, I use X-ray to be very careful as to the start of my resection line. It is a fine balance between doing an adequate resection but also taking too much articular cartilage away. It's important to look at these patients preoperatively and carry out adequate pre-op planning. Visualization is always difficult. It tends to be a battle between bleeding and debris, and so you often have to do some burring, then go back in again with the wand, then do further burring, and then go back in again with the wand. And all of this can take half an hour to 40 minutes at least. It's important to ensure that the whole area is nicely smoothed off at the end, to ensure there's no catching of the labrum when you go into deep flexion. Patients who present after a previous hip arthroscopy with persistent pain will often have had an inadequate cam resection. Once the main work of the resection is done, I finish off by putting the burr into reverse and just smoothing off the junction with the head cartilage to ensure there's no stress risers or anything else that might abrade the labrum. Finally, I flex the hip up and down to ensure that the labrum passes smoothly, and again to ensure that the lesion has been adequately resected. Rehabilitation is essential. We spend a long time developing our rehabilitation protocol. It's carried out in 2 centres, and we've used it in excess of 100 hip arthroscopy patients now. It's certainly as important as the surgery, and it's often useful in the use of preoperative patients as well. So this is an interesting paper published in the British Journal of Sports Medicine a couple of years ago, and what they basically showed was that a lot of high-level athletes will present with a number of different problems all at the same time, usually around the adductors, the iliopsoas, or even the trochanteric area. And I think that just reinforces the picture that patients with long-standing hip impingement will have abnormal muscular patterning around their hip. Don't forget the extra-articular causes, which we mentioned before, and also the weird and wonderful things like osteitis pubis, and particularly the female patients who can present with PID, endometriosis, or ovarian cysts. These patients do tend to be in their 30s and 40s. So what have we learned from the 2 years of hip arthroscopy? Well, the majority do well. That's certainly been helped by our comprehensive rehab protocol. I would strongly recommend that. It also demonstrates the importance of long-term follow-up and the importance of using a well-recognised functional scoring system, and I use the McCarthy one at the moment. If you don't follow up your patients, you don't know how well you're doing, and more importantly, you don't know who doesn't do well. In my hands, we have a 7% total hip replacement rate, and there's a number of groups of patients that don't do well, and they are particularly dysplastic patients, patients with inflammatory arthritis, those with gross damage in arthroscopy, and older females. Where does the future lie? Well, we're already looking at labral reconstruction. We're looking at ligamentum teres reconstruction. Instruments are being developed for that. I certainly think there's a role for retrograde osteochondral grafting to both the head and the acetabulum. We will often scope younger patients with significant grade 4 defects, and once you've removed either their pincer or their cam lesion, it certainly makes sense to me to try and reconstruct the defect. There may be a role for osteochondral grafting in AVN, and I think there's certainly a role for computer navigation in hip arthroscopy. We've started to do these already, and there's an ongoing trial in the Royal Bolton. It's an excellent technique, although it still needs to be refined, and it allows very accurate resection of the cam and pincer lesion under CT guidance. This shows the monitor that we use for the procedure. Thank you for listening, and if you have any further queries, we can be contacted directly on that email address.